All right. Well, thank you guys for having me this morning. As they said, I am the clinical education manager for Myomo. I travel around doing these sorts of things. So have clinical experience as well with orthotics and prosthetics. So if you have any questions on that end, please feel free to ask me. But what we're talking about today is the MyoPro. This is a photo for you guys to look at. It is, like I said, custom designed, custom made, custom fabricated. So it's individualized for each patient's needs as far as the cuff size, the hand configuration. We are able to really get in there and do some unique things depending on the patient presentation. This is a plastic device, so it has a little bit of weight to it. It's about 2.5 pounds or so. We're able to offset that through a harnessing system if that's needed, so that it does not pull on a otherwise compromised shoulder. But honestly, once it's custom fabricated for the patient, the weight tends to go away. We have not really had anybody who has said, oh my gosh, I can't wear this because it's too heavy, with the exception of maybe 1 or 2 MS patients, but they tend to have weight toleration issues anyways. The orthosis itself will determine, is the arm attempting to flex or is it attempting to extend? Once it determines that, it will then augment whatever motion is happening. This can be done off of a very minimal muscle signal. Excuse me. It is detected by a surface sensor. This is not something which requires surgery or any sort of implementation to be inserted underneath the skin or anything of that nature. It's a fully contained unit which is designed to run just off of when the patient wants to use it. So it's volitional, it's functional, and it's portable. We do have an additional option which can be added to the MyoPro. This is actually the unit that I have with me today. We have a wrist unit here which does allow for flexion and extension, pronation and supination, and some radial and ulnar deviation as well. This is indicated for any patient who has full wrist motion. Doesn't mean they have to be fit with it. They can be fit with just a standard static wrist, which just holds the hand in neutral and leaves it there. But it is an option which is now available. That we have found it's been very helpful for increasing independence, increasing functionality, and getting patients used to using range of motion again in their hand and their forearm. So the big question is always, so it's great technology, but who is it actually for? What's the patient that we're looking for? We work with a broad range of pathologies. This is not by any means an all-inclusive list. We have worked with other things that are not on here. We're really more about the patient presentation. But kind of our gold star patients, the ones who really do well with this, are those with brachial plexus injury or some other pathology that mimics a brachial plexus injury, maybe radiation or something like that, which has caused a plexopathy of some sort. An ambulatory spinal cord injury patient with an incomplete, usually around C4, C5. Those patients do very, very well. Along with the brachial plexus injury patients, most of those spinal cord injury patients do have some residual hand motion. So they really do very well getting more independent and more functional once they have use of that arm back. If you have patients that you're seeing with ALS, those patients also tend to have some hand function, so they do very, very well with this as well. The caveat to those patients is ensuring that you fit them very early, almost at diagnosis, so that they have the most time to utilize the orthosis. Patients with traumatic brain injury, depending on their cognition, again, with anything that we do in the world of orthotics and prosthetics, we're always trying to check on what is the patient's cognition. Do they have the ability to turn this on, turn this off, understand how it's used, and can they participate in occupational therapy? Patients with a CVA who have low or moderate tone. Patients with really high tone sometimes kind of fight with this a little bit, and they don't get as much functional benefit out of it. They still do well. They just may not get as much as we would really like to see them do. Multiple sclerosis patients who can tolerate weight, and patients with quadriplegia who have the ability to place their arm in space. That sounds a little counterintuitive, but really what we're talking about there is, does the patient have the ability to mobilize their shoulder in order to make this functional? If they don't have any shoulder flexion, then even if I give them the ability to fully flex their elbow, they're not going to be able to reach their mouth for feeding tasks, hygiene, things of that nature. So even if it's not pretty, as long as they can get that arm from one place to another, that's really what we're talking about with those patients. As I said, not an all-inclusive list. There are multiple other pathologies out there. So really what we're looking at is the patient presentation itself. Who is this not indicated for? So patients who may be candidates for a MyoPro do not have an elbow contracture. We can work with a contracture of about 10 degrees or so, but much beyond that, it becomes problematic. This motor is designed to power from 0 degrees full extension to 130 degrees full flexion. So because of that, if they have, say, a 90-degree contracture, it's going to try and push through that. It's going to be very uncomfortable for the patient. We do have some small range of motion limiters that are on there. However, it does not provide a lock, so the device will still passively extend past whatever the contracture is. So it does tend to be painful, especially if they're carrying something heavy that wants to pull down on that arm. On that note, if they have any pain during range of motion, whether that's during flexion, extension, at the endpoints, whatever that may be, they're probably not the best candidate because it's just going to be uncomfortable every time they move their arm. Cognition we've discussed. If they have the cognitive inability to follow instructions, be that this is how you put it on, this is how you turn it off, can you bring your hand to your face, can you push against this table, those sorts of things. If they don't understand what that means, then they're not going to be a good user. If there's a total lack of EMG signal, they're not going to be a potential candidate because they can't power the device. As I said, it does work off of EMG signals. That being said, this is pretty rare. We don't see this a whole lot, but where we do see it is right after the onset of a condition. So right after a stroke, right after a spinal cord injury, something of that nature. But then if you give them 2 or 3 months and then reevaluate, a lot of the time we do have enough signal that we're able to work with it. I kind of use the example of your classic stroke patient who right after the stroke is really flail. You see them a few months later and they've got just tone in their arms here and you almost can't get it to extend. So same idea there. It's always worth rechecking somebody if you do run across that. If the caregiver's not motivated, if the patient's not motivated, if there's no support, as with anything, that's generally not an appropriate patient. If they have a current or chronic shoulder dislocation, due to the weight of the orthosis, we do recommend not fitting those patients. Subluxation we can work with. We can handle that okay with a harness. But if they do have that full dislocation, 2.5 pounds added to that is not an ideal situation. So we try to avoid those patients. We discussed the inability to place their arm in space. The other one that's listed on here that's a little bit unique is Botox. So if you do have a patient who you are giving Botox to, they should discontinue receiving Botox in their biceps and their triceps if they're using a MyoPro. Botox is an EMG inhibitor, so it's going to cause that EMG signal to fall or to become very, very erratic. It's very frustrating for the patient, very frustrating for the caregiver, and for the care team in general. What happens is basically every week as the Botox starts to wear off, you get a different EMG presentation. So you get a different functionality of the orthosis every single week. So it's very frustrating for patients, and we do recommend that they discontinue it, again, just in the biceps and triceps. They can still get it in the wrist, in the hand, in the shoulder, anywhere else you want them to get it, just in that one localized area. As far as other tone medications, anything that's systemic does not tend to be an issue that we've noticed so far. So if they're on baclofen or anything like that, that so far appears to be okay. Considerations for users with spinal cord injury. I know you guys are the spinal team, so I figured that's probably your largest group that you would be seeing. But again, shoulder motion is going to allow for hand-to-face activities. If they don't have hand function, we can still accommodate that to help them be functional. We can add what's called terminal devices in the world of orthotics and prosthetics. Essentially, we can give them, a clip-on fork, a universal cuff that they can put devices into, something of that nature to basically give them functionality at the hand. The settings on this can be adjusted for a very, very weak EMG, so this is especially appropriate for patients with a very weak or very flaccid arm. They don't have to have a ton of active motion or active strength in order to be able to power this device. And these users will likely need a harness just to help offset the weight and to help protect the shoulder. So what are we talking about as far as outcomes? We are looking at gross motor tasks. So nobody is going to be writing, turning keys, picking up pennies, things of that nature, unless they already have that hand function. So what we're really looking at is, can you do your general ADLs? Can you feed yourself? Can you carry a bag while walking with your cane? If I'm going to reach in a counter above my head, can I put my arm down on the table? Those sorts of things. Some of these may have to be accomplished with those terminal attachments that we talked about, and then some patients will not need that. Some patients are able to do this without. But again, we're really looking at, can you be independent in your basic daily needs? Can you pull up your pants? Can you carry a laundry basket to the washer? That sort of thing. We do see other things that are, more, in our world kind of small, but they mean huge things to patients. We had one gentleman who was a spinal cord injury who said, it's great that I can scratch my face without having to have somebody else come do that. It's great that I can weight shift in my chair without having to wait to have somebody come move me and reposition me. So again, they're small things to us but make a world of difference to other people. So this is a short video, and I'm hoping it's going to be okay because our display is a little choppy, but just with some tasks that patients are doing with their MyoPro. And I have lost mouse function for some reason. Oh no. Okay, we'll come back to that. So the care team itself, the trick here is really ensuring that we kind of have basically a cooperative referrals triangle. So really what we're looking for is the physician, the O&P provider, and then an occupational therapist. The occupational therapist is really key to training the patient to make this a functional tool for them and to really help them learn how to use this so it doesn't end up being something that sits in the closet. The O&P provider is going to be the person who is actually going to check the insurance, fit the patient, ensure that the fit is correct and that things are working appropriately for that patient. And then, of course, the physician is important to provide the prescriptions for the O&P provider and the OT training and for long-term follow-up care and just ensuring that their overall health and needs are being met as related to their upper extremity.
So this is an actual functional enhancement tool. This is not a training tool to augment presence.
Correct.
This is meant to be a life assist unit.
Correct.
So once you have this, the patient purchases it?
It is a customized purchase unit. It's not something that they're going to rent or that they're going to be able to, switch between patients or anything like that. It is typically funded through insurance. Some people will self-fund these if their insurance does not cover. At this time, Medicare is not paying. Medicaid is state dependent. I don't believe we've tried Washington State Medicaid yet, so don't really have an answer for you on that one. But workman's comp, vocational rehab, and most private insurances are covering this.
At what percentage are they paying for these prostheses?
It kind of depends on the insurance policy. As a national average, somewhere between probably 65 to 80% as a national average. But it's really very much policy dependent.
And you had mentioned spasticity as being one of the things you have to look at. What is your experience in terms of modified Ashworth score limitation, 1+ or 2 or
we're
certainly
looking
not
at
3?
less than 3 is really our target goal, but there is some wiggle room in there, but we'd really like to see it at less than 3. But for the right patient, even if their Ashworth scale is a little higher than that, if they really understand that they're going to have to put in extra work to control their tone before this becomes functional, then they may be an appropriate patient as well. Yes?
You made reference to FES technology.
FES, yes, of course. So FES is functional electrical stim, and essentially what happens with that is that the muscle itself is stimulated. So with small electrical shock is given into the muscle to cause it to move. That is pretty much the exact opposite of what Myoelectric technology does and what the MyoPro does. We are not causing the muscle to move. We are simply using the motion that it does have and using that to move the orthosis. Oh, did we get it? Oh, yay. Okay. Go for it. He's the best. Again, so just some general tasks that patients are completing. You will notice this is an older video, so everyone does have just a static wrist. Their hand does not move at all. And so because of that, some of these patients do have some of those, like we talked about, the terminal devices. There's some examples of some harnessing in here. This gentleman here is a C5, partial spinal cord, or incomplete spinal cord injury. A lot of these patients do have low-tone strokes as well. And some of these things seem fairly, minimal to us, like turning on and off the light. But this gentleman says, it makes a world of difference to me if I'm carrying something in my other hand. I don't have to put it down, turn on the light, pick it up, and continue on with my way. This lady talks about the fact that she would not go out to eat in restaurants because she couldn't cut her own food. Her husband had to cut her own food for her, and she thought that was very embarrassing. So now she has that independence. This gentleman has a brachial plexus injury. This is actually just a little bit of a demo unit that happened to fit him. We usually don't recommend hooking up too many patients to units that don't fit them. But it happened to fit him, so he was able to show us moving some things around there. And he had on that harness as well, like we were talking about. Since we have just a few minutes here, let me hook this up. What other questions did you guys have?
So the one question I was, since these patients all have neurologic deficits, shouldn't the shoulder harness be the rule rather than the exception?
We do find that probably about 80% of people do need a shoulder harness. So our recommendation as the manufacturer is that you probably should fit a shoulder harness on almost everybody. However, we do accept that practitioners themselves do have the ability to make that final call after assessing the patient. It is an extensive assessment. The assessment itself is about 14 pages or so that your O&P provider will do to ensure that this is an appropriate candidate and ensure that they are meeting that patient's needs, whether that is what type of wrist unit do they need a harness, do they need terminal attachments, all of those sorts of things.
Have you had patients with neurodegenerative disorders yet?
We have had a couple. We have fit some patients with ALS and MLS. ALS and MS, I'm sorry, those acronyms are wrong. And basically what we find is that the earlier those patients are fit, the better. Some patients will accept it. Some patients do not want to accept it. They just want to try and figure out their life as they continue through their disease process. But those patients are appropriate candidates provided that they do meet the other benchmarks. So. But as you can see, this is a device here. I do have the sensors on my other arm here. It is very responsive to my needs and to what I input into it. So if I engage my triceps, it will extend all the way out to 0 degrees full extension. If I flex, it will come up to full flexion at 130 degrees. For patients who have gone through training with an OT and get very good at this, they can actually stop at mid-range of motion. So they'll have the ability to hold it at 90 degrees or 45 degrees or something of that nature for the task that they're completing. We do have multiple O&P groups within this community who are trained to provide this. We also have multiple therapists within the Seattle area which are trained to train patients with it and get them functional. The key thing really is going to be identifying those patients themselves, and then once we determine where they live and all of that, we can help determine a provider for them. So.
Which hospital system is using this here in this area?
Oh gosh, that's a little hard for me to answer because I do not personally oversee this area. I do know the VA system has provided several. I'm trying to think of exactly. There have been, in the last year, there's been 4 or 5 fit in this area, but I honestly don't know which hospital systems they came out of.
And how do, I don't want to monopolize the discussion, how do you prove value? So what kind of questionnaires or outcomes do you have?
So we have a couple different things that we're doing. One is we are using the DASH with this. It's the disabilities of the arm, shoulder, and hand to determine patients' functionality before being fit and then a little bit later. We have also been lately using what we have termed kind of 3 functional tasks, which basically patients have to list out for us a minimum of 3 tasks that they want to, when I say us, the O&P provider, that they want to accomplish. And then again, after, say, about 3 months or 6 months, depending on what's determined by the provider, they will reevaluate to ensure that they're meeting those goals and then set new ones. And then in addition to that, we do have some OTs who are running their own diagnostic outcomes as well, box and blocks tests and things of that nature. We internally also run a program called the National Outcomes Database, where we check in with users every 3 months to determine what sorts of activities they are doing with their orthosis.
Is the elbow extension strong enough to provide weight shifting when you're giving the electrical stimulation?
It is.
And what do patients find more helpful, the elbow flexion versus the elbow extension? I know it's probably dependent on each patient.
It's totally patient dependent, for sure. And there are multiple modes on this. They can use it so that it responds to just the biceps. They can use it to where it responds to just the triceps, or they can use it in a dual mode. So it's kind of patient dependent on which one they like to use. We do recommend that they are trained in all 3, and there is a standard training protocol as far as they'll start with just their biceps, then they'll move to their triceps, and then put it together in dual mode. We recommend that they learn all of that so that they have the most functional options, but it's really kind of patient dependent on what they like to use. Based on just the patients I've worked with personally, most of mine prefer either dual mode or biceps mode. Yes?
Dr. Chapman, to answer your question, I'm with Hanger Clinic, and we've provided these, we've actually had more referrals out of Evergreen Hospital with their neuroscience department. We're in the process of doing one with Harborview, so we've had quite a few.
Perfect. Yes?
You mentioned the wrist device with the ability to flex, extend, radial deviate, arm deviate, pronate, supinate. A much more complex set of motions than the simple hinge at the elbow.
Yes.
And I assume requiring 6 sensors for each of the 6 motions.
It is, yeah.
Correspondingly greater cost.
So it is not a EMG-driven wrist. It is what we refer to as a passive wrist, wherein the patient has the ability to mobilize it on their own. So the way that it works, if I can slide my hand in there at this awkward angle, is that the patient has the ability to flex it and extend it. They have the ability to pronate and supinate. Let me see if I can get that at an angle that you can see it. Pronate and supinate this way, and then radial and ulnarly deviate it. This can be set so that it is totally free. So if you think of that patient with like a brachial plexus injury who still has full hand and wrist motion, you can set it to where it's totally free. They can move their hand at will. You can also set it to where there's a high tension on it so that patients can reach across and pre-position it into the position that they want it, and it will hold there. Or if for some reason you wanted to, you can totally lock it down. Honestly, if you have a patient that you're going to totally lock it down for, you're probably going to fit them in just a static wrist anyways, because as you said, there is an increased cost on that for that addition.
So none of the wrist or forearm motions are powered?
Not at this time. It is something that we are exploring for future purposes, but not at this time.
What is your success rate in terms of actually getting insurance approval? I've found that other FES devices,
Sure.
Many of your competitors, it's extremely difficult to get any payment, and most of this is borne through very wealthy, self-paid patients.
Right. So it's not a breeze, I won't lie. Most of these go into appeals and denials repeatedly. However, we are finding that probably about 70% of them or so are getting approved. It's a long process. It's not easy. It's not one of these that you're going to write the prescription and the patient's going to have it in 6 weeks sort of thing. We have some that have gone as long as a year but have finally been approved. So it's not an easy process, but we, at our company, we do have reimbursement support for the O&P practices that we do work with. So we take an active role when requested in getting that done. It is a new technology, so we know that it's one of those deals of insurances are going to be a little leery for a while, and so we have been working with them, but overall, it's going very well. I mean, I can be pretty happy with 70%. So.
Yeah, because I'm sure as a P&O provider, you find it frustrating that a lot of the technology and options that you can provide for patients is just not well funded.
Correct.
And that is the usual limiting factor.
Correct. And as always, because we do not direct sell to patients and we do not direct sell to physicians or OTs or anything like that, they are required to work with an O&P provider to get this. So as with any device, any O&P provider can set their own cash sale price. So that can always be worked out at the individual provider level as well. There is somewhere handouts in the room. I think they put them on the back table. For those who want to grab one, please do. My card is back there as well, so if you have any questions, please feel free to reach out to me personally, and I can put you in touch with whoever the appropriate person would be.
Thank you.
All right, thank you guys.